Next speaker is Associate Professor Shahneen Sandhu from the Peter Mac, who's going to be talking to us about leveraging biology for a therapeutic advantage.
Good morning, everyone. Well, thank you for the invitation to speak in this forum. They also gave me the opportunity to come up with my own title, so I came up with Leveraging Biology for a Therapeutic Advantage, and then I was stumped about what to talk about. So I'm going to ask lots of questions. So this is my disclosure slide. So I think the first question is, where are we at? And I think it'd be fair to say that not as far as we'd hoped to be. The THERAP study essentially certainly showed an improvement in PSA responses compared to cabazitaxel. It showed at a landmark time point of 12 months an improvement in progression-free survival. However, it did not translate into a survival benefit, and the caveat there is for lots of reasons that I'm not going to go into. In terms of the VISION study, again, we saw a benefit from a perspective of progression-free survival in the range of 5 to 6 months. We saw a median improvement in overall survival of approximately 4 months, and that was useful, and that resulted in registration of this compound for patients, which is significant. Trying to move it further forward, the PSMA-4 study essentially again showed an improvement in progression-free survival in the range of 6 months, but as you can see there, the survival benefits were not as marked as we would have liked. So one of the key questions I'd like to pose to this really clever audience is, can we start to interrogate biology? Can we start to understand what drives primary resistance, because this is a common theme? In our cohorts at Peter MacCallum, we've actually taken a lot of care of trying to pick the patients and enrich the subset of patients that are most likely to respond based on criteria that Michael has set up, looking at lack of discordant disease and using certain cutoffs and thresholds for PSMA expression. But nonetheless, a subset of patients are consistently primary resistant. So what drives that? Is that biology? Is it inherent radioresistant biology? Can we learn from the various radiotherapy trials that have been done previously and our understanding about radioresistance in that context? Is it tumor volume? Is it heterogeneity of the target? Is it the metabolic signatures that Anna is alluding to? Can we turn this around with some of the newer alpha emitters that are coming into clinic? What about the approach of combination strategies? Can we turn this around? Or can we look at reducing this subset of patients with combination treatment? And I suspect the answer is yes, we probably can, by using some of the best agents in the clinic, such as APRIs and chemotherapy. What about another question? Dosing adaptation. I think it's key to think about the subset of patients not to treat, the subset of patients we should move on quickly to another line of treatment. So stopping treatment early, I feel, is paramount. And I think hopefully there is going to be more research in this space. And from my own practice, my sense is 2 or 3 cycles of treatment is sufficient to stratify patients into responding versus non-responding, move on to something else. I was reflecting on a conversation I had with Howard Soul from PCF yesterday, and the striking cost of PET scans in terms of defining the subset of patients who are not responding. So developing biomarkers that are cheaper is important. So stopping treatment also in patients who are having an early response is useful. And so can we as a community develop a working framework of using maybe PET scans or perhaps even the SPECT-CT scans, because those could be more widely available, certainly much cheaper, circulating biomarkers, blood in a tube, to try to personalize who not to treat and who to stop treatment in the context of an excellent response. Can we personalize the activity and the schedule administered based on tumor volume, maybe renal function? And I envisage perhaps in the future we'll get to a point where you can plug in someone's PET scan parameters and a computer will say, well, this dose, this schedule for this patient, and then we can start perhaps to design randomized control trials of AI decision around dose and schedule versus standard cookie cutter approaches. So just to extend that thought process, The dose schedule adaptation, look here, these are patients that I've treated on the PRINCE trial. Should we treat patient A, B, and C the same way? These are their baseline scans. Certainly we did that. So the question, do all patients need the same number of cycles, the same amount of activity? Can we use the patterns of disease across sites to define the sort of mix and match of radioligand therapy patients should have? And can we use AI as it comes on board to personalize treatment and hopefully mitigate toxicity? This is something we do at Peter Mac. This is a slide from Michael, but it's certainly something that we do, and I think we do very well. And we've embedded it in all the clinical trials that we run in Australia, where we're really looking to see, can we stop treatment early? Can we halt treatment in patients who have lost target and reuse those supplies of treatment down the track? Along the lines of developing circulating biomarkers, you've already heard from Heidi, and Ed will speak as well, about the utility of circulating biomarkers to stratify patients who are doing well versus the ones who are not doing well. Here we've looked at circulating tumor cell clearance, PSMA positive clearance versus tumor volume, and you can see in red the subset of patients that clear essentially have the long-term responses, and the hazard ratio there is 0.23. So how do you move radioligand therapy in earlier disease? I think it's fair to say the paradigm of multimodal treatments up front is biologically sensible. And it's well established, and it's probably highly useful in the context of highly heterogeneous, differently molecularly driven disease. But I think in that context, we really have to think long and hard about intensification in the subset that need intensification and de-intensification to improve patient outcome where they don't need that level of intensification. Considerations also about the interaction between the target and AR signaling, which is one of the mainstay targets in this disease. Now, this is relevant when you target PSMA, because of course, when you target AR and block AR, PSMA goes down. So how do you combine the two? Has to be very thoughtfully done, possible, but thoughtfully done, but maybe less relevant in the context of some of the newer agents coming on board, where perhaps there isn't that level of regulation between AR and some of these targets. What about long-term tox? Judiciously, I think we've got to use it up front because we don't understand long-term toxicity yet, and sequencing might become relevant, induction followed maintenance strategies. So where we're at, this is basically a patient of mine, one of the first patients I treated with lutetium, and the reality is recrudescence of disease. So rationale combinations, how and when and why. And here I put up some basic rationale. Radiosensitization is obvious. There are good radiosensitizers in the clinic. PARP inhibitors are probably furthest on in its development paradigm, not going away in the treatment from prostate cancer. DNA PKs, ATR, ATM, and all of these agents are in the clinic. They have liability, so one has to be thoughtful about the dosing, the schedule, and how they're combined. But it is possible. One also has to be thoughtful about the patient selection, including whether you take the approach of induction followed by maintenance. Chemotherapy are obvious partners. What about antibody-drug conjugates? They're certainly coming into their fore. What is the impact of the payload? Do they have an impact on the microenvironment? And then I am a firm believer, and I'll say it here, that the only way we're going to cure this disease, if that's what we want to do, is we have to leverage the immune system. And I don't think we're there yet, and we've got a long way to go, but things that we could consider looking at is immune checkpoints, T-cell engagers, personalized cancer vaccines, and CAR T cells as well. But we have to think about how we use these. I think the area that is going to explode in the next 5 to 10 years is the targets. And because the technology to look at targets in tumor material is starting to increase, and this is data that's been generated by Anna's team, looking at the Cascade cohort, looking at basically both PSMA, but also some other targets that are relevant. So some of the work we're currently doing is looking at our studies. We've embedded a lot of biomarkers, as you can see there. This is basically, we want to look at the baseline PET parameters, serial longitudinal PET parameters, correlate that to the sort of cellular level, what's happening in the blood, your PSMA positive and negative cells, what's the genomics of your PSMA positive and negative cells, how do they change longitudinally, what is happening at the ctDNA level, and then layer it on to try and understand biology. We've been trying to understand the genomics at a single CTC level currently, and this is work that's been done by Shiva and Santosh and David Good and myself. We're also starting to look at the immune landscape of pre- and post-treatment biopsies, correlating genomics with immune profiling of the pre- and post-biopsies, but then also looking at the circulation as well. And just some examples, trying to sort of look at the areas of PSMA positivity and making sure you capture some of the white cells as well. And we've been able to generate some nice data, which we're starting to interrogate now, really looking at, all these baseline on-treatment and progression biopsies of the different subsets. What becomes obviously clear, and this is a theme that comes out again and again in the context of radiation, is you do draw in immune cells, but you can also draw in some of the negative immune subsets, such as your macrophages. And so I think we have to be thoughtful about how we approach this. We're looking at mass spec, and this is being done in collaboration with William Chen, a young radiation oncologist. I just want to quickly move on to two things. Is there more immunogenicity of alpha particles? This is a paper that's been previously published in Cancer, and really looking at in a melanoma B16 model, which is known to be immune suppressive, the combination of alpha radioligand therapy targeting melanocortin receptor in conjunction with immunotherapy in that red line, resulting in cure in 43% of patients. And then what's interesting is the dosing schedule might be important, and it may be that the lower doses may be lower activity may be more immunogenic. So last couple of slides now. Novel targets, I think key concepts to consider, novel targets and combinations. We want durable responses. We don't want just 6 months, we want years. So durable responses, but we need to balance that with tolerability. Type, dosing schedule matters, positioning of the existing in the existing therapeutic paradigm, patient selection in the context of mitigating risk, stopping early in non-responders, stopping early in super responders, dosing schedules, again, to mitigate toxicity, and defining and studying the cumulative toxicity. Future directions, novel targets, novel traces, modifications to radioligand dosing, manipulation of expression of the target, rational combinations across cancers. Thank you. I'd like to thank the patients, our donors, and my colleagues, both in the clinical space, the nuclear medicine space, and the translational space. Thank you.